We're about crossed 50 participants, as it's always been happening with our national webinars. So good morning once again, and welcome to this national webinar on medical education from the Department of Medical Education, JIPMER Pondicherry. Today's session on simulation education for patient safety. Well, years ago, 20 years ago maybe, I attended a workshop on disaster management as a postgraduate. And as a part of this disaster management workshop, we played a small game. It was called the mass casualty game. It was conducted as what I now know was a tabletop exercise. All that was used was a blackboard and chalk, and the facilitator listed patients on the blackboard using chalk. Listed 10 patients using chalk on the blackboard, and there was a timeline of every 5-minute intervals. The participants, most of us postgraduates, were divided into different team members who were dealing with this mass casualty. Every 5 minutes, the decisions that we took made an impact on the condition of the 10 mass casualty patients. They had cards for the decision, and cards for outcomes. So we could see patients who were improving, patients who were collapsing, patients dying as well. So about 10 minutes into this exercise, most of us, I think all of us, forgot that this was a game, as we were frantically trying to save our patients. Till date, it's 20 years now, till date, I remember this as the finest example of simulation-based training that I've ever seen. Little did I know then that the architect of this game then would go on to become one of the leading experts of simulation-based medical education in this part of the world. And it is indeed a fantastic opportunity for us that we have him here conducting this webinar. I've known Dr. Dinkar Pai as my teacher, the professor of surgery when I was doing my undergraduation here, then post-graduation, and finally as a senior colleague. At present, he is a professor of surgery and the director of the Simulation Center at Mahatma Gandhi Medical College and Research Institute. He's actually done a lot in this area. He's obtained a certified healthcare simulation educator certification from the Society for Simulation Healthcare USA in 2016. He's a Team Steps Master Trainer, a member of the Singapore Society for Healthcare Simulation. He's on the editorial board of Advances in Simulation, which is the official journal of the European Society for Simulation of Health Sciences. He's a visiting consultant for so many medical colleges in India and abroad to guide their simulation programs. Several chapters that he has written on simulation. In his CV, he has listed that he's been active in simulation-based healthcare education for the last 10 years. I don't think that is true, because if you go by my example, that's 20 years and maybe even more than that. I welcome Dr. Dinkar Pai to this webinar and invite him to start the session. Thank you so much.
Thank you very much for your kind words, Nandakishore. Fortunately, because of your slow internet connection, there were a lot of gaps, which I think shortened the whole introduction. I am grateful for that. And thank you for remembering the game that we played, which was essentially a triage game, which, if I am not mistaken, we did it when you people were undergraduates, not postgraduates. So it was in the mid-90s that we ran the game. And I mean, at that time we did it without even knowing that it was simulation. Now simulation has come into its own right as a teaching learning modality, and I am happy to see that medical educationists, especially in this country, are now looking at simulation as an important modality of teaching in addition to all the existing modalities. And this webinar is in line with that belief, and I am very grateful to you for the introduction, to Professor Jayaprakash Rajan of the Medical Education Unit and all the other staff of Medical Education Unit JIPMER for having given me this opportunity. So, I would like to welcome questions in the chat while it is going on, and we will try and answer the questions as and when we maybe at the end. And I would like some interactions during the session. So, without further ado, let me start with my slides. So, I hope all of you can hear me clearly. In case there is any issue, please type in the chat, and I am sure Nanda Kishore or Dr. Jay Prakash, who is the other co-host, will address these issues. So, I hope all of you can see my slide. So, if let me start now. So, the topic for today is basically simulation education and patient safety. So, if you look at this topic, there are two essential components to this topic. One is simulation education and the other is patient safety, and each of these is a huge a vast topic by itself, and I am sure that I cannot do justice to it in the 45 minutes to an hour that I am going to speak. So, my idea is I am going to introduce all of you to the basic concepts of patient safety and quality care, and also give you a bird's eye view, if you like, of how simulation can be used to address training needs in this area. Okay. And as I said, because this webinar is going to leave a lot of questions unanswered, I welcome those questions from you, and we will try and answer as many as possible at the end. So, I am very acutely aware that I am sitting in a medical education unit, and I know that I will be vilified if I do not mention the objectives of my talk in the beginning itself. So, these are essentially the objectives of this particular webinar, where you would be expected to be able to outline the importance of patient safety, list the two main types of medical errors, components of quality care, and outline the use of simulation training for error correction. So, these are the four essential objectives that I have for my talk. Now, let us go on to what we mean by patient safety. It is a very broad topic, and the WHO definition, as you can see here, is essentially it is talking about prevention of errors and adverse effects to patients associated with healthcare. Okay. So, this is the WHO definition, and I think it is a very apt definition, and the key here is the word prevention. We do not act after an adverse event has happened, rather we are trying to prevent these adverse events from happening. Now, this is an important concept of so called never events that was brought up by the National Quality Forum. I think it was about almost 12 to 15 years ago, and this basically talks of events that should never happen in healthcare, and they have divided these never events into surgical, procedural, product patient protection events, care management events, etc. So, surgical events which should never happen, for example, would be leaving a gauze behind at the time of surgery in a patient, operating on the wrong side or on the wrong patient, so these are never events for surgical procedures. Similarly, product or device events, if you use a contaminated product, let us say the hip implant that you have inserted has already been contaminated, that should be a never event as far as product or device events are concerned. Or if a device is used inappropriately, for example, you are defibrillating a patient who does not need a defibrillation, and as a result of it he has got an adverse event, that could probably or you use the wrong electrical charge on the defibrillator, these could probably conceivably be considered as product events. Patient protection events essentially is to protect the patient from harm due to things that are not directly related to healthcare, for example, suicide prevention in a patient. So, a patient should never commit suicide in the hospital, and yet we have seen nowadays every day in the news we have instances where COVID patients are jumping from balconies or committing suicide or found dead in the bathrooms. These ideally should be never events, which should never happen. Care management events are events related to the direct care of the patient by the healthcare providers. These are the ones where the healthcare providers are directly involved in the error making. It could be things like medication errors, etc., which are part of the care management. Environmental events are events occurring as a result of problems in the environment within the hospital. This would include, for example, a patient slipping on a wet floor and fracturing their hip, or getting electrocuted because of an improper electrical socket or an electrical connection. So these are all environmental events. Radiological events are things like, for example, taking a patient with a metallic implant into MRI. That is a radiological event which should never happen. And criminal events, again, unfortunately we have no shortage of these criminal events in our country, and I am sure in other parts of the world as well. would be things like sexual abuse of a patient, or stealing of babies is a very common occurrence that has been seen repeatedly in our newspapers. These would be examples of criminal events. So, all these categories have events listed under them which are classified as never events, which means in an ideal world these should not happen, but of course, we know we are not living in an ideal world, and these errors and these never events do happen from time to time. But these give you a benchmark of what we are trying to aim at. Now, patient safety is probably the buzzword now. Okay, when I was in training and even when I was a junior faculty, we sort of vaguely knew about the concept of patient safety, but we never really paid attention to it as a unique concept in itself. We did whatever we could to keep the patient safe without knowing what we were doing and why we were doing it. Now, it has become a catchphrase, it has become a buzzword, and it has become the be all and end all of healthcare. And this cartoon epitomizes what we went through, and I do not really think this cartoon is that much of an exaggeration, where the professor is saying it's okay, it's a teaching hospital. Some people just have to learn the hard way when the patient has an adverse event because of a student's intervention. But these things did happen, and unfortunately they do still happen, and one of the aims of this webinar would be to try and see how we can reduce these events completely. Now, coming to why we are talking about patient safety so much now, when it is patients have been unsafe for donkey's years. So, earlier, if you like, there was no awareness of the concept, as I already told you. Patients were ignorant, especially I am talking about in the developing world, in India, the type of patients we saw, and even today some of them that we see are ignorant. They believe that the doctor is God. They believe that whatever the doctor does is good for the patient, and say, doctor, whatever you want to do, you do. Even if you are trying to inform the patient about the treatment options, they say, doctor, we leave ourselves in your hands. You are the best judge, you decide and you do whatever you want to do. So, that patient ignorance is still there, but it was much more in the earlier years. A fatalistic attitude, this is especially true for Eastern cultures. It is all written in our fate. If I have to die, I will die anyway. Does not matter that I have gone in for a hernia surgery in the hospital and I have died. So, it's my fate. So, these sort of fatalistic attitudes also did not encourage the medical fraternity in India, and I am sure in other similar countries, to take to patient safety in a serious way. And there were low expectations from healthcare for all patients. They knew, okay, I am going to the hospital, if I survive, it is God's grace, I am going there expecting to die. So, they did not really have that much of an expectation when they went, especially into the government hospitals, the poorer patients, the backward sections of society. This is all they could afford, this is all they could get access to, and unfortunately these hospitals also were not well equipped, and the doctors sometimes were not well trained, especially at the primary health center level. Some of these very well, we had only compounders who were manning the primary health center. So, there was overall low expectation from healthcare. Now, however, things are changing. Okay. So, the concept of patient safety is now being emphasized the world over. It is coming into even the undergraduate medical education as a term by itself. The EdCom module is going a long way in addressing this issue. Patients are becoming more and more aware of their rights, and there is a lot more legal cases being filed against doctors nowadays for so called medical malpractice. Healthcare delivery has become much more complex. Newer technologies are coming in every day, and let us face it, all of us are not that well versed with all these newer technologies that are coming in. I know a very famous incident which happened, and whatever I am going to tell you, the practical examples are things that I have witnessed with my own eyes. This was a surgeon who was using a surgical stapler for an anterior resection. Now, when I say anterior resection, it is removing the rectum and then joining back the colon back to the anus, so that the patient can pass motion normally. And this is for those of you who are not aware, I apologize to the people who are well aware of this procedure. Is done so that the patient can for cancer, and the patient will be able to pass motion normally. Now, staplers have come in as a boon to allow us to do a very low resection of the rectum, so that we can put the colon back to the anus. Unfortunately, in the early days of staplers, this particular surgeon was not very sure of how the stapler works, but he wanted to try it for a case which we were doing an anterior resection. Now, the way the stapler is used is you have to tighten it, fire it, and then loosen it, so that it becomes loose from the tissue, and then it is pulled out. He did the tightening, firing, but he did not loosen the stapler, because he did not know that you are supposed to loosen the stapler, and he found that the stapler was stuck. and there was nobody else in the theater at the time who could help him, and he thought there is some malfunction of the stapler, and he converted that anterior resection into an abdominoperineal resection, which means he removed the anus along with the colon, and the patient was he ended up with a permanent colostomy. So, this is an example of newer technology which the surgeon was not familiar with, and we see examples of this all the time. We have seen horrendous examples of laparoscopic surgery done by surgeons who are not familiar with laparoscopy, but because they are expert at open surgery, they believe they can do anything and they go ahead and do it. So, these are all examples of newer technologies which are causing issues because we are not familiar with them. Sicker patients, because of improvement in healthcare, the type of patients we are seeing today are much more sick, and they would have died much before they reach the hospital or soon after reaching the hospital in the earlier days. Now, we are able to keep them alive for longer, and this obviously means that the complexity of treatment also increases, and this is another area where patient safety becomes more acute. Knowledge now is easily accessible to everyone. Half the time patients who come to me have already researched their disease on the internet, even the ones who are coming from villages, they have some idea about what their disease is like. And so, it is all the more the responsibility of the healthcare provider to be up to date with his knowledge and to make sure that they are able to answer all the patient's queries, and patients are aware that these are the errors that can happen in my care, and higher expectations of the patients. Because of all this, it goes without saying. Now, just a few statistics which some of you may know, to some it may be horrifying. In 1999, there was a landmark paper produced by the Institute of Medicine in the US, which called the Agency for Research and Quality, AHRQ, Research and Quality. So, Agency for Healthcare Research and Quality, who brought out this document called "To Err is Human," and at that time they said, in their estimate, in the US there were 98,000 deaths roughly due to medical error every year. People were shocked at this number, but later on a number of when it was researched, it was found that this number was actually a pretty true depiction. Even today, the number of patients who are suffering harm in hospitals is the equivalent of 800 jumbo jets crashing every day. So, you can imagine the number of patients who are undergoing harm as a result of errors in the hospital. I would like to put to all of you a hypothetical question. I do not know how many of you, if given the chance, would go in for bungee jumping. Bungee jumping, where you are basically an elastic band is tied to your leg and then you are thrown off from a height. It is pretty terrifying experience, but of course, it is all attempts are made to keep it safe. It is supposed to be a high risk event, okay, a bungee jump, and unfortunately healthcare comes in that same category. Your chances of getting harmed if you enter into a hospital as a patient is as much as if you were to go bungee jumping. This is just to put the amount of medical errors that happen in hospitals in context, and it has been estimated that the range of medical errors in hospitals is from between 3% to 10%, and this I am talking about is in the developed world. Okay. In the developing, but it has also been estimated, because we do not have data from the developing countries unfortunately, that 2/3 of errors that happen, all medical errors that happen worldwide, happen in developing countries. And this is because of the lack of working equipment. We are all familiar, at least when I was in training, we knew the OT lights would go off and then we have been practically operating in torchlight. Our diathermy will be very old and the cables will be frayed, etc. Lack of proper infrastructure. Even today, there are complaints every day about the infrastructure available in the COVID care facilities all over the country. Lack of education on patient safety, because frankly speaking, all of us have grown up without being aware of this concept, and there is no demand drive from patients, which I already alluded to earlier. So, these are some of the reasons why most of the medical errors that happen are happening in the developing world, but unfortunately we do not have much data on this. Why do these errors occur? One statement is very obvious: errors are an inevitable consequence of human performance. That means there is no such thing as a zero error. Regardless of whichever industry you are in, you may be in the safest industry, there is no such thing as zero error. All you can try to do is to minimize error. So, it was Reason who came up with this concept of the Swiss cheese model of error happening, error occurrence. Essentially what he said was that an error is not the result of one major incident, rather it is a culmination of mistakes or events, small events, which all ultimately join together to make the end error, the big error at the end. And he likened this to a number of Swiss cheese slices. As you all know, Swiss cheese has got holes in it, and if you can stack up Swiss cheese slices side by side, these holes will not be in alignment. Each hole in each slice represents the potential for an error to happen. So, only when all the holes in all the slices are aligned, the light can go through. In other words, an error can happen at the end. So, even you can see from this that errors that do happen are very rare, but the fact that so many errors are happening, you can now extrapolate backwards and imagine how many incidents would have occurred where we did not even realize were occurring before we saw the errors that we are actually seeing now. So, this is a very important concept that has come in, which says that errors are not because of one big cataclysmic event. And so, he talks about, for example, there may be culture, staffing level and performance, there could be processes in the hospital, equipment, facilities, all these things join together before finally the error comes in. So, this is a very important model on error occurrence that is good to understand. Now, when we talk of medical errors, there are basically two types of errors. One is active errors. These are errors which are made by the healthcare provider, and we have all come across this. You know, it could be because of communication and teamwork issues, which is usually the commonest reason. More than 70 to 80% of medical errors happen not because of a lack of technical skill, but it is because of a lack of non-technical skills. In other words, a patient does not die because a surgeon does not know how to control bleeding or how to suture, or an anesthetist does not know how to intubate. Patients die because of lack of leadership, because of lack of situational awareness, because of lack of improper decision making. So, these are all examples of non-technical skills which are resulting in errors. So, it could be because of communication and teamwork issues, it could be lack of standard operating procedures. The WHO checklist has now come in universally and this is being applied worldwide for patients who are coming in for surgery. Unfortunately, you can bring checklists into human endeavor, but you cannot take human endeavor out of checklist. What I mean by that is, we start using these checklists in an improper way. We are using these checklists day in and day out, in the theater every day, that finally it becomes almost robotic for us. Patient's name is blah blah blah, and the surgeon, without even verifying, says yes, 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 yes. In airlines industry, this does not happen, and the reason this does not happen is because every flight there is a cockpit voice recorder, and every flight the pilots undergo simulation training on frequent basis, and all these things are seen, emphasized, re-emphasized and drilled into the pilots to say, even if there is one mistake here, you can lose your license, and that does not unfortunately exist in the medical world. So, we start using these checklists also very mechanically, and that is again a big source of error. Fatigue, when I was in the UK, we used to have a 1 in 2 rota. That means 48 hours on, 24 hours off, again 48 hours on, 24 hours off, and you can imagine how tiring that was. Nowadays, there are a lot of regulations which are regulating the number of hours that doctors work, but fatigue definitely introduces a major element as far as errors are concerned, because when you are tired, you are more prone to make mistakes. And of course, inexperience of the person with the disease or the process that he is dealing with. I already mentioned about the inexperience with technology. Even if the case is very complex, we may make errors simply because we are ignorant of what we are dealing with. Then we have the latent errors, which are the system factors in the background which led to the error. And ultimately, if you analyze most of these errors, you will find that the root cause of these errors lies with the system. So, how do we get rid of errors in the hospital? We have to correct the system. Okay, just to tell you again, this is from my personal examples, and all these are not, these are not errors necessarily happening in this country. I have worked in a number of countries, and some of these things that I am talking about have happened abroad, where the healthcare, so-called developed countries, where the healthcare is supposed to be much better. There was an incident once in a hospital where a agitated patient was there in casualty, being seen by a surgical consultant and an intern. And this patient needed, I think, a CT scan or an MRI, I do not remember exactly what, and the surgical consultant told the intern to administer midazolam, which is a sedative. The normal dose of midazolam is around 1 to 3 milligrams. You know, I am not an anesthetist, but this is usually the dose that is given. Now, what happened was a surgeon asked the intern to give 3 milligrams of midazolam. The intern turned to the nurse and asked for 3 milliliters of midazolam. Each milliliter of midazolam contains 5 milligrams. The nurse, without questioning the intern, drew up 3 ml of midazolam, and the consultant also is hearing this exchange, but maybe he is not paying attention to it because he is busy with the patient. The nurse hands in the 3 ml of midazolam to the intern. The intern reports back to the consultant saying, I am injecting 3 ml of midazolam. The consultant says go ahead, and the patient received 15 milligrams of midazolam rather than the 3 milligrams that he was supposed to receive. He went into respiratory arrest. Fortunately, he was resuscitated, put on ventilator for some time and recovered completely. But having said that, there was a fact finding, and obviously some action was taken in this issue. The second incident that has happened is in a patient who had a diabetic foot with diabetic neuropathy, who needed I think it was a usual foot bath or something, and normally we use warm water for the foot bath. So, this intern was tasked with the job of doing this, you know, getting a foot bath for the patient, and an intern asked the nurse, where do I get the warm water? The nurse said, oh, the boiler is there, get it from the boiler. Intern got boiling water, didn't check the temperature of the water. The patient's foot was immersed in the boiling water, and because the patient had neuropathy, the patient did not even realize this happening, and finally by the time they realized and took out the foot, it had very bad blistering. Luckily the patient did not lose the foot, but it was one of these so called never events. Let us analyze these mistakes. Do we really blame the person on site for doing this? That would be the natural thing. You know, we will blame the intern in the second instance, and in the first instance to say, look, you should have known the dosage of midazolam, or you should have known to check the water before you did it. But if you see, a lot of babies, especially in western countries, which are the so called developed countries, are brought in with burns on their buttocks, etc., simply because their mothers immerse them in boiling water without checking the, or very hot water without checking the temperature of the water first. So, these errors are happening not just because of errors at the individual level, but at the system level. These interns are not being trained on how to handle these diabetic foot patients or how to give drugs. In fact, in that hospital where the midazolam was given, they have a policy that nobody who has not undergone a sedative drug administration course is allowed to administer sedatives. That consultant was new in that hospital and did not know the fact that the intern is not authorized to give that drug. The intern had gone through an orientation program and knew that he was not supposed to give that drug, but he still gave it because the consultant was telling him to do it. The nurse knew that that was the wrong dose, but she did not want to speak up, and so she did not speak about it. So it was a lack of training, which is probably a system responsibility in both the instances. There should be a better way of getting hot water or warm water for foot bath rather than getting it from the boiler. So, again that would be a system problem. So, in other words, what I am trying to tell you over here is that we do not just ascribe error to the end point, you know, that is the last person who carries out that error, who makes the error. There are a lot of things earlier which have caused the error, and it is important therefore to do a thorough analysis of the whole incident analysis to find out why it happened and to see how you can prevent it. If you do not do that, if you just blame the intern in this case, you are not going to be able to correct the error, and these errors are likely to recur. Okay, a very important question: do we practice what we preach? So, there was a study which was done which looked at Bihar, China and Delhi, 3 countries, and in Bihar it was diarrhea, and in Delhi and China it was tuberculosis. Now, the standard thing for diarrhea is to give ORS, oral rehydration solution, and for tuberculosis acid fire bacilli and chest X-ray, and we will judge the success by seeing how many of these things are ordered or given. Now, a group of doctors underwent a training program in which they had clinical standardized vignettes, patient vignettes, where they had standardized patients and they interacted with the standardized patient in a training environment. They knew it was a training environment, and this patient comes and complains of diarrhea, and the doctor, what he does, he gives ORS, and or this patient complains of cough with expectoration and weight loss, etc., etc. What does the doctor do? He gives he orders a chest X-ray and he orders AFB, right? So, you believe that this doctor knows his stuff and this doctor is safe to practice in the community. The very same population of doctors, they followed them up in actual practice, and they found that the patients who are when they are faced with a real patient, okay, the white bars indicate real patients in the clinical environment, they forgot all that. ORS patients, you see, sorry, the white bar represents a clinical vignette, and the green bar represents standardized patients. Standardized patients were those who went to the doctor's clinic in the work environment pretending to be real patients, and just to see how the doctor does. And you see the number of people who were administered ORS when they went to the doctor's clinic with diarrhea is much lower than when the doctors knew that they were being observed and it was in the training environment. And the same thing is true in cuts across countries, and it cuts across diseases. So what this means is that when we are creating an artificial environment for training and we are training people, they are acutely aware of what they are supposed to do and they generally do it. But these same people, when they go back to the clinical area, they just go back to what they were doing. So this is a very important aspect that we have to address. Without bringing this change of behavior into the workplace, you cannot say that true education has happened. So before I talk about how to use simulation education for preventing errors, the first disclaimer I would like to make is education is not the only answer to patient safety, as we rightly saw. You may do as many number of simulations in the simulation center as you want, but unless this is translated into real time action, these errors will continue to happen. So it has to become an institutional and a personal philosophy. It requires a lot of regulation, it requires a lot of training and reinforcement in the workplace for this to become a reality. So just by bringing them to a simulation center and giving them a simulation training is not going to help. Now, the threat and error management framework is an important framework which was basically developed by the airlines industry to measure the interrelationship between safety and human performance in rapidly challenging situations. You know, especially in an airliner, when there is an emergency, it is a rapidly changing situation. Similarly, if a very sick patient comes into the emergency department, there is a rapid change in that patient's situation. So in such situations, to look at the interrelationship between safety and human performance, this threat and error management framework came in. And what conclusion it was is that pilots will naturally make mistakes, but what we need to do is we need to maintain the safety margins by training these flight crews, not only to prevent threats by detecting and responding early, but and to avoid mistakes. So a lot of the simulation training that pilots undergo is aimed at this, and this has seen a remarkable reduction in airline incidents. And you know, I am sure all of you know that air travel is the safest way to travel right now because of this. Okay, so what are the components of the threat, this TEM? So the threats, events that occur beyond our influence. For example, Nandakishore was alluding to a mass casualty event. It is something that is happening outside the hospital. We cannot control it. Or a patient who is coming in because of multiple from a road traffic accident with multiple injuries. These are things which are threats. We cannot control that. How do we respond to these threats is something that we can actually control. And what we need to do in this situation is we always need to train for the unexpected. You know, there is a very famous saying that the more you sweat in peacetime, the less you bleed in war. It essentially means you practice so that when the real event comes in, your chances of making errors is much less. Okay, so you need to anticipate and train for these. Errors are actions or inactions that can result in an adverse outcome, like leaving a gauze in a surgical wound. So how do we learn and how do we correct ourselves? This is where the checklists come into their own, but these checklists, as I already told you, should not be applied mechanically, and there should be some standard operating procedures as well in place. Third is undesirable states, which are operational conditions where an unintended situation results in a reduced margin of safety. For example, you have not noticed that the laryngoscope battery is depleted, and just when you want to intubate, you find that the bulb is not working, or a doctor fatigue, for example. These would be examples of undesirable states. How do we cope with this? So we need a system based correction. You know, there has to be a check back every morning. The nurse has to check that all the emergency equipment in the emergency department is in working order. We have to make sure that the doctors' rotas and rosters are such that they do not face excessive fatigue, which is more easily said than done nowadays with the COVID menace upon us. So this also requires a SOPs. So this is about the threats, errors, and management components. Now, how do we therefore develop patient safety awareness? So as I said, education is important, but it is certainly not the only component. So in education, simulation falls, there is a very big role to play in this area. The other thing is on the job. In fact, one of the best ways you can train in patient safety culture is by being a role model for your juniors, because this is how most of the people who are working in professions such as medicine learn. They learn by observing their role models. Now, you have to of course role model it in simulation, and you have to train them in simulation, but you also have to carry that over into the clinical area where you are a role model for the students, where you are emphasizing patient safety all the time. That is on the job. And you have to develop a culture of safety in the institution, which would start at the administrative level, where you have to have a look at a quality assurance division, look at all the incidents that happen in the hospital critically, analyze them without affixing blame, and try and find out how can we minimize these errors. So, and then follow up and make sure that these errors are definitely reducing in number. So, you need to develop a system for this. Unfortunately, what happens in India, I am sure other countries also the same. We think about all this because of the pressure from regulatory bodies, because the regulatory body is saying that you have to do it, so we do it. And the moment the regulatory like NABH or NAC or whatever it may be, as soon as the regulatory body is out of the picture, we go back to square one. That is not a good system management. We need to incorporate something so that we do not need to do anything extra when these regulatory bodies come. You are already working in that framework, and therefore, it is part and parcel of what you do in your daily life to show to the regulatory bodies. That is the way we should be. Okay. Now, this I saw in an interesting cartoon. Do you is there really safety in numbers? That is, the more the people are there, the better it is. We have got this famous adage which says too many cooks spoil the broth, and there was this cartoon which said that patient safety is equal to 1 over n, where n is the number of anesthesia professors in the OT. It could very well be surgery professors. I am not pulling the anesthetist leg. The cartoon just mentioned anesthesia, so I put it over here. So, the less number of anesthesia professors there are in the OT, the less chances of error basically. Now, so when we talk of patient safety, we are talking about quality care for these patients, and so we have to look at what constitutes quality care. What do we mean by quality care? Now, the classical definition of quality care was by negative definitions, that is the 5 Ds: death. If you have an unexpected death, or then that is a issue, quality issue. Disease, disability, patient discomfort, patient dissatisfaction. So, all these were negative parameters which were measured to measure whether you are giving appropriate quality care. Now, we have moved over from this negative to a more positive matrix, where we are saying patient care which is safe, which is effective, patient centered, which is in time, efficient and equitable. So, this is what would be the definition nowadays of what quality care means. Now, how do we therefore achieve this? How do we train the healthcare workers? Simulation, if you are talking about training exclusively, again I will give you the disclaimer that training is not the only way, but when you are talking training, you are talking simulation. Simulation is the way you can train these people to achieve this quality care. Okay. Now, simulation is used for training for both technical and non-technical skills. I will not go into the details of these. I have already talked about this a little earlier when I said most of the medical errors happen because of issues with non-technical skills, and this is again an area where we are not training our undergraduates, we are not training our postgraduates, and it is a pressing need of the hour to train especially our postgraduates and our practicing physicians in teamwork skills. Okay. And that is one of the missions that I have for myself, that I am trying to inculcate this in as many institutions as possible to get them on board for using teamwork training skills to make a better, safer healthcare for the patients. A skilled physician automatically becomes a safe physician. A lot of the time these skills are, of course, most of us have gained it by experience. So, an experienced physician is definitely a safe physician, but nowadays you have other ways of getting the skills in the simulation center. Now, it has been shown, there are a number of articles now, it is beyond doubt that simulation training is effective for skill transfer. So, these are some of the papers, like one which said computer simulation training enhances patient comfort during endoscopy, or simulation based learning reduces central venous catheterization insertion complications in an intensive care unit. Like this, there are a number of articles. So, virtual reality training improving operating room performance. So, this is beyond doubt. There is nobody can argue today that simulation training does not work. It has been shown that it works. So, what are the areas therefore which we can focus on by simulation training for improving the this quality patient care quality care and patient safety as a result. So, there are three main areas that I want to talk about. One is teamwork, the other is professionalism, and the third is administrative management issues. Again, I will not go into the details of all this. So, teamwork, for example, there is a very good online resource available for those of you who are not familiar, again from the AHRQ, the American the Agency for Healthcare Research and Quality Assurance, which has brought up this team steps model. The team steps stands for team strategies and tools to enhance performance and patient safety. It is an online training model where any of us can undergo, and unlike most of the things from the US, this is totally free, and you can become a team steps master trainer simply by doing an online course without leaving your home. And they talk about 4 key tenets of teamwork: leadership, situational monitoring, mutual support, and communications. And they have a various scenarios dealing with each of these models and training, how to train for each of these situations. And then these are linked to the output from the healthcare professional in terms of either attitudes, performance, or knowledge. And you can see that the patient care team is surrounding this whole behavioral model, and this patient care team does not only consist of the immediate patient care team which is taking care of the patient, but also the ancillary services like I do not know, the kitchen, the physiotherapy, the radiology, so many other factors, even the cleaners or the ward boys, etc., all would come into the patient care team, and all need to be part of a cohesive whole in order for patient safety to happen, in order for quality care to happen in a safe way. So, most important, I would say, if you ask me to tell one important thing in teamwork, it would be communication, and it is shown that communication errors are responsible for 2/3 of adverse events, and it has also been shown that simulation is effective in teaching and evaluating communication skills. The other area I just want to touch upon is situational awareness. It is part of a component of situational monitoring, and this is the self awareness that an individual has of the situation all around you, so that you can deal with threats as and when they appear rather than missing them for a long time because you are focused on something else. The enemy of situational awareness is intense focus. So, if you are focused on a task, let us say you are busy intubating a patient, there is no way you can maintain situational awareness, which is why time and time again it is emphasized in teamwork that the team leader should not be involved in doing any task, he should be maintaining an overall situational awareness. And this cartoon typically tells you what technology brings to us. In Singapore, when I was there, this used to happen regularly, that we are facing the computer and we are typing in the patient's history, or and the patient is sitting behind us and we are not even looking at the patient. So, this doctor is so worried about the patient's cholesterol level, he does not see that the patient has got a number of arrows piercing him. Okay, so I just play a small video for situational awareness. This video, because it is taken from the YouTube, so it is not very, it is an advertisement, by the way. It was an medical insurance advertisement, insurance company, and it shows a pair of ambulance drivers who are having an old ambulance, and in that ambulance they have a particular sound for a patient going into arrest and needing a defibrillation, and they are attuned to that sound, and then they get a new ambulance where that sound means something else, and you can see what happens for yourself in the video. Okay, so I suppose all of you could understand the gist of that video. They are so attuned to the sound of the defibrillator, which indicates a shockable rhythm, that the ambulance, the healthcare provider inside the ambulance is just listening to the sound of the ambulance parking, the reversing alarm, and assumes that the patient is in cardiac arrest, and this is a very common error that happens in medicine. We may laugh at this, but it actually happens very commonly, and it is called fixation error, where you get fixated on something that this means this. You know, it is like the Pavlovian behavioral response where ringing of a bell induces salivation. So, here this guy is attuned to the fact that when you have this sound, it means that the patient is in arrest and needs defibrillation, and these errors happen very, very commonly, and I have seen it happen when we run simulations for team training. We see this happening all the time, and these fixation errors are, generally speaking, more the more experienced you are. An experienced anesthetist will never believe that the tube is in the esophagus in spite of all the evidence that is coming there. He will have a fixation error that I cannot put the tube in the esophagus, and whatever I am seeing is not because of the tube being in the esophagus, but he will try to find every other excuse for it. A surgeon similarly, I mean, you take whichever healthcare professionals, you know, we tend to get fixated on the fact that the error is not caused by us. So, after having just touched upon the various aspects of teamwork, we go to the next thing, that is professionalism, which is defined as those attitudes and behaviors that serve to maintain patient interest above the physician's self interest. In other words, it is a very what do you say, nebulous area, a nebulous zone, which people are not very familiar with, people are not very comfortable with, they just do not understand what is meant by professionalism. But essentially what it means is how a physician conducts himself or herself. When I say physician, I am including all healthcare workers, because they are also professionals, how they conduct themselves vis-a-vis their relationship with their fellow professionals as well as their relationship with the patient. And this again is a component of the EdCom module. I am very happy that that is coming into the medical education now, which are the primacy of patient welfare. Whatever we do should be with the patient welfare at heart, and we should not let extraneous conditions like a VIP or you know how much money the patient can pay and all come into the picture. Easier said than done, I know, but this is what is the what we should be striving at. Second is patient autonomy. Give the patient the right to choose what they want to do or do not want to do. So, you know, I can remember a patient who came who had a unexpected seizure, had a very big he came, saw the neurosurgeon, had an MRI, had a huge tumor which was looking exactly like a glioma, and he was advised neurosurgery, at least to take a biopsy and confirm the diagnosis to make sure that it was what it was, and he refused. He said, no way I am getting this done. He went on to alternative therapies, into homeopathy, other therapies. Now it is, I think, 2 or 3 years after that, and he is still doing very well. The point is that patient had the right, or he chose not to go through a procedure, and all of us felt, including myself, that what the patient was choosing was wrong, that he has got no business to choose this. And but it is patient autonomy, it is patient choice, it is what they want to do, and they are taking their, you give them all the information that is necessary to make that choice, but ultimately the choice should be the patient's choice, and we should not try and influence that patient's choice in any way. The third, of course, is social justice, where it is distributive justice, where we make use of the available resources and give it equitably to the entire population. It may mean, for example, that because a particular transplant is very expensive for a given patient, we do not go through with the transplant even at the detriment of that patient, but rather use that money for a much larger good where we can save a number of more patients. It is, you know, you have to cut your coat according to the cloth you have. It is a reality of life, and distributive justice is there, you know, we cannot avoid it. So, what is important about professionalism is that it can be taught, and of course, traditionally it was learnt on the job, and I still believe learning on the job is excellent because most of us, as I said, learn from our peers, and simulation is now being used to teach the tenets of professionalism when they work together as teams. The final part that I was talking about, the three things, teamwork, professionalism, is management. It is very important for our hospital administrators and managers also to go through simulation, and we use simulation scenarios for management training. Dr. Nandakishore was alluding to a tabletop game that we did, which involved a mass casualty event. I was running that for undergraduate medical students. I have run it also for postgraduate medical students, and there was we had gone from JIPMER NTTC, we were in a disaster management module, and we had gone to Kodaikanal to conduct a workshop for deans and administrators of medical colleges, and in that workshop we ran the same thing, but the focus of us was different. How, as administrators, will they manage this mass casualty event? and it was a very successful thing. So, the same module can be tailored right from a very basic level, undergraduate level, to a very senior administrative level without much modification. It is only the process that is different, the material is the same, the delivery is different. So, they need to be trained in this. Process testing for new facilities. When I was in Singapore, we were a new hospital, entire new hospital was being built to us, and when we shifted to the new hospital, for a month or more before we shifted to the new hospital, each of the areas in that hospital was tested by taking in simulators, making them have either a code, coding there, or requiring some urgent intervention, and seeing whether that area was suitable for us to intervene. And based on the experience, we made some design changes. It could be something as simple as, in one area we found that the table was too high for them to do the CPR. So, we said get the footstool and keep it there. In another, the endoscopy suite, we found that the C-arm was interfering with access to the patient, so that we could not do an effective CPR. So, the suite had to be redesigned to have the endoscope to the C-arm in a place, so that we could still access the patient. So, it is very important to do process testing not only for new facilities, but also with in situ simulation. Take a simulator into your emergency department, let the students have the people there interact with that simulator as though it was, let us say, a trauma patient or a patient coming in with a myocardial infarction or whatever, and then a lot of issues will come up which can be debriefed, and then you can improve the emergency department to handle these real patients in future. So, these are examples of ways in which simulation is used in process testing, and that is also very important aspect of simulation which people sometimes do not realize. So, in conclusion, I would just like to say, how does simulation impact patient safety? By simulation training, patients are already exposed to trained physicians. It is a learner centered experiential training, which all of us in medical education know that this is the way to go for adult education. It allows for a safe environment where you can afford to make mistakes and learn from them, so that you do not replicate that in real life. It gives you a uniform exposure to curricular content. So, when you are relying upon patients for your exposure, some students may have a patient of a particular type, others may not have it. So, this prevents that. Improved incident reporting and safety culture can be inculcated through simulation without the blame game. What is essential is not to blame the individual at the root cause of the event, but look at the entire process and see where it went wrong. Assessments also can be done using simulation, which are relevant and in line with clinical safe practices. Build that into your assessments. Do not simply assess in an artificial way what you expect the students to do in real life situation. So, again, the objectives of my seminar were to outline the importance of patient safety, to list the two main types of medical errors, which was which we have already covered, the listing the components of quality care, and outline the use of simulation training for error correction. So, I think this should be the buzzword for now, sim or sync, and this is a view of the sea of Pondicherry. So, from Pondicherry, greetings to all of you, and thank you all very much. Thank you.
For a very thought-provoking and engaging, I would say, primer of a talk for simulation in medical education, especially in view of patient safety. The last slide, your thank you slide, reminded me one thing to the audience, that you are an avid and an exceptionally good photographer. Okay, so the chat box has been a little busy as you were talking, and we'll start looking at some of the comments or as well as questions that have come up. So, Dr. Shant mentioned, what about irrational drug prescription? I think this is when we were talking about the types of errors that may happen. What about irrational drug prescription? It could be willful or out of ignorance, but can anyway harm the patient.
Okay, it's a good question. Personally, I feel it very difficult to believe that irrational drug prescription could be willful, in the sense that we deliberately are wanting to harm the patient. I know the TV news is now full of Sushant Singh and how he has been drugged and etc. I am not going into that at all, but generally speaking, as a healthcare professional, I would say that we do not really aim to harm a patient when we give the drug. However, the most of the time we give an irrational drug prescription is because of ignorance. and that ignorance is because we have seen our seniors do it, because we see our fellow practitioners do it, because the drug company guys come and tell us this is the way to prescribe this drug, and we don't bother to cross check or look at the facts ourselves. Medicine is a lifelong learning process, and a lot of us forget that. So, the answer to this again would be training to prevent irrational drug prescription, not by training them on the uses and abuses of drugs with specific drugs in mind, but rather inculcating them in the behavior of seeking the answers when they are dealing with an unfamiliar drug. Go online, check it out, see what are the problems and see what are the issues with prescribing that drug. So that what I would like to train these doctors in is not in training them in pharmacopoeia, but rather in training them on how to training them to compulsorily look for answers whenever they are faced with something that they are not familiar with. I hope that answers the question.
It does. Dr. Avik Prabhu wants to know what is the ideal time to introduce simulation based patient care to our undergraduate students.
If you ask me, I would say introduce it in school, but for undergraduates, I know for example in the National University Hospital in Singapore, they use it right from first year, where very simple, they make a simulated patient bleed. There is a mannequin and you can see the physiological changes on the screen where the BP is going down, the pulse rate is going up, the CVP is going down, and they ask the students to observe the changes on the screen, find out which one happens first, which one happens next, and then they try to explain the physiological reason behind these changes. Okay. So, for anatomy now we have very good anatomy simulators like the Anatomatch table or Spectra. There are different companies which have different products, and there you can dissect the body layer by layer, and you can do what we could not do when we were doing dissection with cadavers, in that is following one structure throughout its entire length. So, if we had to look for example at the radial nerve, when we were dissecting the upper arm, we saw a small segment of radial nerve in the upper arm, then we saw the next segment lower down. So, it was very difficult for us to conceptualize how it will be overall when it goes through the body. You can follow that through in these things. So, right from year 1, I feel that you can easily introduce simulation. What we say about simulation is the use of simulation is limited only by your imagination. Thank you.
So, it's an interesting point you made that you really expect this to happen.
Sorry, say that again.
So you said it should happen, the education should be introduced from the level of school, high school.
Well, yeah, it's not happening at the level of high school, but I can tell you that a number of institutions even in India are introducing simulation in the first year, including our institution. We have a very robust standardized patient program where we bring in these housewives, we have trained them to be standardized patients, and the first year students are given a module where they interact with these patients, first of all to take the history, to get the demographics, to understand the student patient concerns, and we have also formative OSCEs where we look at their communication with patients. So, it is already happening.
Thank you, sir. Then this is a question from Malaysia, Dr. Madhi. Professor Dinkar, how do you think simulation lab based drills and practice compare with virtual based drills and practice, that is VR, AR, MR, in terms of effectiveness in improving clinical practice?
Okay, it is a little complex question. First of all, entire online training in simulation, probably there are limitations to it. With the technology that we have available today, definitely a physical interaction with a mannequin makes a lot more sense than online. Having said that, when you are talking about VR or AR, you must remember AR, especially augmented reality, when we talk about, it is a mixture of reality and virtual environment. A classical example is a Microsoft HoloLens or a heads up display in some of the newer cars. So, what it does, it overlays a VR, a virtual reality environment onto an actual physical environment. So, you can have a patient like one of these healthcare companies like CAE Healthcare has got this augmented reality module wherein you have a pregnant patient, and let us say the patient has shoulder dystocia. You wear the AR glasses, you can see the baby inside, and you can, when you are doing the various maneuvers, you can see how the baby is responding and how the shoulder dystocia is getting relieved. But it requires a physical mannequin. Similarly, VR environments, I in fact was a PhD examiner for one of the Dutch universities recently on a simulation thesis in which the research project, one of the components of that research project was using VR for laparoscopic training. They found that you have a simple laparoscopic simulator with a screen and virtual reality simulator, and you are interacting with it. What they did was they gave the participant a VR headset and they recreated an entire operating room around him with distractions, where the surgeon was pestered by somebody or some music came up or some phone was ringing. And with those distractions, they tried to create a realistic environment, because they found that these distractions occur in real life. So why are we not using them in training? So there is a big role for AR and VR in the simulation environment itself. You can introduce VR and AR to make it more realistic.
So just to extend that question, sir, why do we need to look at these two things as different entities? Why not, each one complementing the other? It's not necessary that you should have only a simulation lab based or a virtual based. I suppose both of them together become a part of simulation based training.
Absolutely. Ultimately, we have to look at hybridization, we have to look at hybrid models, and as technology improves, the gap between what is real and what is artificial is narrowing very, very rapidly.
So there are few comments, both of which say lack of training during internship may be the cause. I'm tell you, lack of training during internship may be the cause.
Maybe the cause.
Yeah, so this is a comment from two of the audience.
I think a lot of the people in the audience are senior medical teachers, and of course they have their own personal experience, and I fully agree with this. But I would not stop at saying lack of training in internship. I would say lack of training from first year onwards. The medical curriculum in this country is what I would like to call a schizophrenic curriculum. It's got a split personality. Right up to the final year, you are only drilling them with theory. The moment they come into internship, you expect them to be skilled in doing procedures which they have never been trained for. And therefore, it is a very artificial divide between a medical student and an intern. It is supposed to be a continuum, a continuous process. So I would say, let us not just focus on training in internship. The training should start from first year. Now the integrated curriculum has come. I don't know how well it will be implemented. Ultimately, the proof of the pudding lies in the eating. So the implementation has to be there, where we integrate the whole process and start the procedural skills training from first year. We are trying to do that in our center, so that by the time they come to internship, they are already well versed. When I was in the UK, quite some time ago as a registrar, I had the experience of working with the UK interns, and I had the experience of working with Indian interns here. So the difference I would like to say about the UK intern and the Indian intern, even in those days, because of the way of training, if a patient comes to you with acute abdominal pain and you are suspecting acute pancreatitis, the Indian intern will see the patient, and then he'll call you and he'll give you a list of 10 different causes of acute pancreatitis that this patient might be having, and all about the etiopathogenesis of the disease, etc., and then leave you to manage the rest. The UK guy will not know what the patient is having. He'll see that the patient is sick, his BP is low, he'll put in a central line, he'll take all the investigations that are necessary, and he'll say, look doc, I've got a patient with abdominal pain, I don't know what's going on, but I've done whatever is necessary to stabilize the patient, kindly come and see. So these are two extremes. What we need is somewhere in between. Thank you.
I think that's fair. So there's a question, I think, which never dies down, and many of them may have the similar observation to make. And this is from Dr. Thiruvarul, who says investment on infrastructure for simulation is huge. Not many institutes are willing to do that.
I think there is a very good point here. The point that we have to look at it in a different way, to be very honest. The problem with setting up simulation centers as a classical business model is people are looking for tangible return on investment. If I put in so much money, how much money am I going to get out of it? What they don't look at are the intangible benefits. For every patient error that you prevent, you are saving a huge amount of cost for the hospital. And if your quality of care and quality of healthcare delivery is better than other hospitals, people will flock to you. How do you ensure that? You can do that by simulation training. These are intangible benefits where it's not very easy to put a number on it. And let me tell you, money is available in most of the institutions. It is the will to spend that is lacking. A corporate hospital, for example, will much rather spend money on an extra MRI machine rather than the equivalent amount of money to set up a training facility for their doctors, because they can see that returns from that extra MRI machine straight away. So when we are looking at return on investment from simulation, we have to factor in the intangible returns and factor in the fact that we are here to provide an educational service which is going to improve patient care in our hospital and thereby lead to a lot of savings for our hospital.
Thank you, sir. There are a lot of appreciative comments on the chat box, many of whom have thanked you for an excellent presentation. There is one question from Dr. Som Prakash Basu, AIMS Rishikesh, who says in a learner-centered education system, how much is must-know area of patient safety, considering any permutation of error is possible? So his question is, how much is must-know?
Okay. When we are talking about patient safety, I believe patient safety by itself is a must-know topic, because ultimately that is what we are all aiming towards. The problem is, as Dr. Basu rightly points out, there are so many permutations and combinations that are possible, and it is not possible to address all the permutations and combinations. However, if you look at various patient safety articles, you can distill all these permutations and combinations into a few, maybe 10 or 12 basic principles of patient safety. So, if we can train our students in these basic principles of patient safety, we hope that by extrapolation, when they are faced with a specific clinical problem, they will be able to tackle that problem in a safe manner.
I think there's a question on a tangent as well here. Thanks, sir. Can a patient autonomy be sometimes curtailed? So it's referring to corona situation wherein a patient wants to go home but is not allowed to go.
Patient autonomy, when we say, we are talking about patient autonomy within reason. In other words, a patient autonomy exists only, I mean, this again, I am not an expert on ethics, so I am not going to, I don't claim to be an expert on ethics, but to me, patient autonomy pertains to the patient only. In other words, what do I decide for myself? Patient autonomy does not mean I can decide what is for somebody else. In a way, as a COVID patient, if I go out and then infect others, I am affecting other people, and therefore patient autonomy does not come in. It is not my right to go out and infect others. I can decide for myself whether I want treatment. For example, I want to be on ventilator for COVID or not, I can take that choice. I don't want to be on ventilator, I am happier to die with the COVID, is my choice. But it is not my choice whether I go out into the community and then spread the disease because it is affecting others. So I think patient autonomy has to be looked at in that light, that it is for the patient himself, and if the patient is going to be, as a result of that autonomy, causing harm to others, then I think obviously that cause no harm overrides the patient autonomy in that sense.
Absolutely. The larger good overrides an individual's.
Precisely.
This is Dr. Fernando. As many medical colleges are developing their simulation lab, what is your advice for the faculties embracing simulation based education? I think it's a very broad.
Yeah, I was just about to ask Dr. Jayaprakash, do I have another extra 3 hours? Then I can answer that question. Basically, the MCI has got a requirement now for all medical colleges to have a simulation center, which is a good step. What I feel is that they have not gone far enough, because the type of simulation they are requiring is very, very limited in its nature. I feel that we should be doing more, and I believe it's up to the individual institutions to decide how far they want to go, how much money they have, and also to keep in mind that simulation does not necessarily equate to money. There are a lot of low cost simulation solutions. In fact, we are going to have a conference in December, which will be a virtual conference where one of the focuses will be on low cost simulation. So there are a lot of resources out there which are available, and it would be really up to the individual institution, and I don't think this is the right time and place to give advice for specific institutions.
Thank you. So there's a question from Tushar. He asks that you said in a controlled scenario like a simulation, one tends to be accurate, but later in real life situation we tend to make more mistakes. How do we go about addressing this gap? I think this has also been repeated by some other audiences as well.
Yeah. So this is where the difficulty comes. The problem is we are to blame as teachers, as facilitators. I go into the simulation center and I behave in a different way in the simulation center with the participants, and the moment I go back to the ward and I am dealing with real patients, I change my behavior. I go back to my old behavior. When the students who are coming into the simulation center and following me into the ward see that, they know that whatever I am talking, okay, it's okay, whatever he's saying in the simulation center is fine. When he is there, we will just behave as though the way he expects us to behave. I think there's some technical term also for this in medical education, right? When you are under observation, your behavior will be different than when you don't know that you are under observation. So let us just behave that way, and then in the regular clinical area, we will do what he is doing. So, ultimately we are responsible for training our students. So, we have to lead from the front, which I already mentioned in the talk. Our behavior has to be such that the student knows that the simulation center behavior is not an artificial behavior. The mannequin may be artificial, the environment may be artificial, but our behavior should be genuine, and we should display that in the real environment as well. Without that, this is not going to happen. Thank you for that question.
That was the Hawthorne effect.
Yes, Hawthorne effect for us, I thought for kidnap victims, right? Or no, for medical education, correct. Yeah. Correct.
So I'll club the next three questions because I think you can answer them together. One is Dr. Shivarajini Pradeep, who asks, is simulation-based training confined to clinical subjects or it can be extended to paraclinical subjects? Dr. Manisha, what are your views regarding simulation training replacing dissection of cadavers? And third, Dr. Shantini, what type of simulation is recommended for first year students for anatomy?
Okay, so basically, yeah. So, basically I think there is a big role for simulation in pre and paraclinical subjects. In our institute, for example, when you talk about paraclinical like pharmacology, they are doing task training with the medical students for drug delivery systems, how to give subcutaneous, intramuscular, intravenous injections. We have the blood bank people who are using simulation to how to have safety during blood transfusion. So, they mislabel bags, and it is all in the simulation center, and they have a module in which they are teaching how to collect samples for specimen samples, for example. All this can be done in the simulation center. For anatomy, I have already talked about the anatomatch table. I am not a subject specialist. It is very difficult for me to say whether these newer modalities will replace cadaver dissection. I do know for a fact that most of the world the cadavers are more and more difficult to come by, and there are a lot of ethical and other considerations when dealing with human remains, and so they are moving to different forms of education. And if I go by my own experience in dissection, to be very honest, in a leathery formalinized cadaver, the anatomy that I saw was absolutely nothing like what we see in real life. In fact, I remember in JIPMER I was fortunate enough that when we were in anatomy, our anatomy professors made it a point to bring in fresh cadavers sometimes. I remember still, this is how fresh it is in my mind. The cadaver was fresh, the memory is also fresh in my mind. A head was fresh, head was brought in where we were shown the brain and the parts of the brain, and we could actually feel the almost liquid nature of the brain, which was, we never expected that, because to us in a formalized brain was very hard structure. So, I believe that cadaveric dissection is also simulation. Actually, it is not real, it's not real life situation. So, in that sense, it is giving you just the same input that technologically more advanced simulator would give.
Thank you, sir. There's a very important comment that Professor Ananthakrishnan makes, that simulation is an intermediate in the continuum of progression towards real life training. Lack of patience or lack of patient's willingness to be examined cannot result in simulation being the end in itself. Unfortunately, this is happening in some institutes.
Yes, I fully agree there, but the problem is what you are looking at is a situation where either you have nothing or you have something. We know for a fact the ground reality is that we do not have patience, and if we have patience, in the ideal world, I fully agree, we should, as it is a bridge between real life and the basic training. There is no arguing against that. But what do you do, especially in today's circumstance, when we absolutely are in a situation with the back to the wall where we do not have patience? I would say at least expose them to simulation. It is better doing that rather than not giving them any sort of training at all, saying that we do not have any patience. But the ideal situation, it would be both.
I think it's a fair enough argument, sir. We have about 126 participants online now. I'm reaching the last question on the chat box, so those who want to ask questions directly can get ready. This is from Arun Varghese, Dr. Arun Varghese. What is the scope of simulation in psychology and psychiatry?
It will be a very opening up Pandora's box if I start talking about the role of simulation in individual subjects, because then everybody may ask in their respective subjects, but essentially, as I told you, the role of simulation is only limited by your imagination, and I believe that the key element in psychiatry or psychology is communication, and you can very easily use standardized patients for communication. You can even use mannequin based simulation where the mannequins now have the capability of communicating with the caregiver through a microphone which is having held by the facilitator who is outside the room, so it looks as though the voice is coming from the mannequin. So ultimately, if you understand that simulation is not only about plastic and metal, but also human beings can be simulators, which we call as so called warm simulators like standardized patients, you will understand that there is a very big role for simulation in psychology and psychiatry.
Thank you, sir. Dr. Jayaprakash, do we have time to take a few questions from the audience directly?
Yes, sir. We can take few questions, oral questions.
Any audience who's got a question that they want to directly ask, please unmute yourselves and go ahead. So as somebody gets ready, there is a question as to how you can get onto the TeamSteps program, and can you recommend any website or resource material?
Okay, just
regarding Analytic Lab,
yeah, it's the Agency for Healthcare Research and Quality, AHRQ. Best is you just Google TeamSteps, that is TEAM STEPPS. I'll just put it in the chat. So if you just Google TeamSteps, it is there in the chat. You will go to the AHRQ website, and you can there's a link for becoming an online master trainer. There will be they start the courses at specific intervals, so you can join the next course and totally free of cost. And the final as part of the training is you will have a live interaction over Skype or Zoom or something with a trainer from the US who will ask you to do a short presentation, and then based on your quality of your presentation, they then give you the certification for a TeamSteps master trainer. Even if you don't want to get that formal certification, there's a lot of resources in that TeamSteps. They give you good ways of teaching these non-technical skills which you can make use of.
So the slide that you had showed about the Swiss cheese model, no? The one where you I just noticed that culture was one of the slices, Swiss cheese slice. But I think especially in terms of patient safety, culture is something that pervades at each of those levels.
Yeah.
All behaviors are determined, like, if you look at patient safety, it's not easy to just imagine the hospital as a safe environment, as an island, where people all over the city engage in unsafe behavior. You can't expect safety to come as one element in the hospital by itself, while on the roads people don't follow safety. I mean, it's just like wearing a mask and then riding with a mobile phone on your ear.
So I mean, I think that's a very valid point. So here, I mean, my interpretation of culture in that context, in that particular slide, was culture in terms of our cultural background, if you like, rather than the culture in terms of our behavior. So I can give, like, I was there for a very short time in Saudi Arabia, and because of the difficulty in examining women because of cultural sensitivities, there is a very big risk of missing very major illnesses, especially like breast cancer, etc. And I've seen that here in India, well-to-do patients who are because of that culturally we are very shy. They wait until a very advanced tumor develops before they go and seek professional help. So I was probably talking about culture in that sense. What the slide is saying, that can be one of the components that contributes to error, but you have rightly pointed out that it's a culture is all pervasive in society, and the essential cultural ethos of the community has to be changed if you want to make a useful change in behavior in the clinical setting.
Thank you, sir. Dr. Jayaprakash, would you like to add something or any comments?
No, sir, I think we can conclude. We can conclude. If there are no oral questions, we can conclude, sir.
Sir, thank you so much for an excellent session. I thank all the audience for engaging very constructively in making this webinar useful for all of us. Thank you once again. I hope all of you stay safe.
Feedback
and stay apart from each other and keep communicating. Thank you very much.
Thank you so much, all of you, for a patient listening. Thank you.